One of the things we found in Naomi, which came as a surprise to us, was that a small group of people in the study were given not medically prescribed heroin, but a licensed drug called hydromorphone. And this was done on a double-blind basis, so we didn't know who was getting it, and the patients did not know who was getting it. And to our surprise, the people in the study couldn't really tell the difference between the two drugs, and it appeared that hydromorphone was equally effective. The problem is that it was a small number of people, so we couldn't be conclusive about that. So we've decided as part of SALOME to test whether it is in fact true that hydromorphone is as effective as heroin.
SALOME is a study that is going to test alternative treatments for long-term heroin dependency. We are going to test two medications, one of them heroin, and the other one hydromorphone, a pain medication. And we will provide these medications in injectable and oral form. The aim of the SALOME study is to engage the most vulnerable street heroin users into treatment and stop the use of illicit heroin.
Hydromorphone is the drug whose trade name is Dilaudid. The people may have heard of that. It's licensed for pain. And it's a member of the opiate family, just like heroin and Demerol and OxyContin and many drugs people will have heard of.
Treatment with injectable opioids have a very small but very important role in the addiction treatment system.
So the goal of the SALOME trial is to, first of all, establish whether it is in fact true that this licensed drug, hydromorphone or Dilaudid, is as effective as heroin in this particular group. And if that turns out to be true, we think it will make this kind of treatment much more accessible, because the use of hydromorphone would be much more acceptable in a lot of places than heroin, which carries a stigma, as we all know.
Well, if the SALOME study shows that hydromorphone can go head-to-head with heroin as an alternative therapy for people who failed, optimally provided methadone, then I think that this should be part of the treatment continuum that's available through physicians prescribing who are providing substitution therapy for opioid-addicted people.
The second question we're looking at in SALOME is whether after a while of stabilizing people, we could switch them from the intravenous form of the medication to an oral form. And if we show that that is also effective, it could make the treatment much more accessible, because we wouldn't have to use the kind of specialized clinics that we need to use for the injected medication.
After 12 months, your participation in the clinical study is going to end, and we are going to transition you to other treatment available in the community.
Everyone who comes into this study or into this treatment is already using heroin. They're using it 3 or 4 times a day, and they've been using it, for example, in Naomi, on average 16 years. So no one coming into the study is going to become addicted to heroin. They already are. Secondly, you would think, for example, in a study like Naomi, that if you give free heroin to people, they're going to use more and more and more. And in fact, what we found is that the average dose in Naomi was less than half of the maximum allowed. Not only do we not create heroin addicts, but they don't go up and up and up in their use of heroin.
If we connect that with counseling and other psychosocial activities, this will stabilize them in a way that they are not need to be involved in any criminal activities, that they could actually reorganize their lives, find housing, do all the stuff that you need to be reintegrated into society, and also deal with your psychosocial issues like the different concurrent disorders I've mentioned. And you can add on that all the necessary treatment for physical illness and for mental illness you need to provide to address a complex situation.
One of the advantages of having a SALOME type study where you are giving medicine to people that are really entrenched, who don't interact with the healthcare system, is that every time they come in to inject, it is an opportunity to engage with them, get to know who they are.
The idea is to get them in out of the alleys, get them into a medical clinic with doctors, nurses, and counselors, and try to break that cycle and get them to a point where they're willing to move on to other kinds of treatment.
I mean, living on the street, I can't imagine being easy. And the stories that I've heard from the people that I've been honored to meet, it sounds like a horrific way to live. And so the drug and alcohol counselor is someone there that can help them work through all of their trauma and all of their horrors, and also just to be there to guide them through the process of the study as well.
One of the best ways of dealing with drug addiction is harm reduction. And things like Insight, the SALOME Study, and things like that are absolutely key to that, because it not only gives us information from an academic perspective, how drug addicts work and think and what's happening physiologically, but also because it brings people into contact with healthcare workers for the very first time.
So we're going to take care of our patients in this study on many different levels. We're going to provide them with a place of dignity, privacy, and respect. We're going to treat them with a non-judgmental approach. We're going to treat them and care for them a lot like I would care for anyone's mother, father, or sibling. So the study is open from 8 a.m. to 8 p.m., 7 days a week. When a client arrives, they will enter the building by buzzing in, and the receptionist will let them in. So welcome to the clinic. All of our participants have agreed to have their photograph taken, and we have a log on the computer. And so when the receptionist recognizes who's at the door, they'll buzz them in. They come and check in at the reception desk. We give them a little barcode, which is then swiped, and all their data is showing up on the computer that they have arrived. The client then goes and waits in the reception area where they'll be seen by a nurse and assessed to make sure that they're able to take their medication, make sure they're not intoxicated and they're feeling well. This is a great opportunity to make sure that, if there's anything that we're going to need to follow up with them at that point in time, we can. The client then walks into the injection room, is seen by another nurse. Their barcode is then swiped again so that we know that they've entered the injection room. Their medicine needle is also barcoded and swiped, so we can actually make sure that they're getting the correct dose. So once I've been checked in by the nurse in the injection room, I will be handed my syringe with medicine as the patient. I can then come and sit down here at the chair and table, and the mirror is here for the staff to make sure that their people are injecting properly, and also to make sure from a safety point of view there's no diversion of medication. The patients then are able to come and inject. The nurse is here to help if needed, and that's really more just a supervision type of help. They don't actually do any of the injecting. They can just help them find a vein and those sorts of things. Once they have finished injecting, they show the needle to the first nurse, which is then barcoded and swiped. So all of the medicine is accounted for, and it is dumped into a biohazard bin. The client then goes back into the reception area where they can sit and wait for about 15 minutes after to make sure there are no adverse events after the injection. They are seen by the reception room nurse again to make sure that everything is okay, and then they're able to leave.
The SALOME study received scientific approval as well as ethical approval. We are also working with Health Canada to ensure our procedures are safe and the medication is safe to give to participants. The research portion of the SALOME study is funded by the Canadian Institutes of Health Research, and the clinical services are going to be provided by Providence Healthcare.
Providence Healthcare is supporting this research because it is so aligned with our mission, vision, and values. We have a very long tradition that comes from a faith-based background. If you think back to the 1890s, a group of religious women who saw a need in the community and founded St. Paul's Hospital. And since those early beginnings, we have continued to reach out to the most marginalized and needy in our community. We really need to get from this research a better understanding of what the right approaches are to treating addicted populations. And in particular, our hope would be that we would find a new approach for those people who are addicted and not benefiting from current approaches to care.